So still continuing on the adverse effects of succinylcholine. So the next one is hyperkalemia. Okay, so giving succinylcholine will usually increase the plasma concentration of potassium. Okay, and this is due to the depolarizing action of the relaxant, okay, of succinylcholine. And when we activate the acetylcholine channels, so movements of sodium into the cell, okay, is accompanied by movement of potassium out of the cell, okay. So when potassium goes out of the cells, it goes into the plasma, increases the plasma concentration of potassium. And this slight increase is usually tolerated well by most people, and usually does not cause dysrhythmias, okay, does not cause abnormal rhythms of the heart. The next unwanted effects of giving dexamethasone is increased intraocular pressure, okay, increased intraocular pressure. So this is something that you use to measure the intraocular pressure. So when you have increased intraocular pressure, that's what we call glaucoma, okay. Next is increased intragastric pressure. The increase in the IGP, intragastric pressure, is presumed to be due to fasciculations of abdominal skeletal muscle. Okay, so because of the abdominal skeletal muscle, which is fasciculating, so it's like having small contractions. Okay, at first because of the succinylcholine, so that's probably the cause of the increase in the intragastric pressure. So increase in the stomach pressure. Next is increase in intracranial pressure. Okay, and we don't know really the mechanism behind this, because it's a temporary increase in intracranial pressure, but somehow this increase does not occur after pre-treatment with non-depolarizing neuromuscular blockers. Next one is myalgias. Okay, succinylcholine can cause myalgias. Okay, the incidence rate varies from 0.2 to 89%. So it's a wide variability there, and more frequently after minor surgery, especially in women and patients who are ambulatory, patients who can move around. Okay, so it's probably secondary to damage produced in muscle by the unsynchronized contractions of adjacent muscle fibers, okay, just before the onset of paralysis. The next adverse effect of dexamethasone is Masseter spasm. Okay, so this is a frequent response in adults and children. There is a high incidence of spasm in children, which may be due to a not enough dose of succinylcholine. Okay, so it's an underdosage of succinylcholine may cause a spasm in the masseter muscle. Okay, so this is the masseter muscle. Okay, you have spasm here. Okay, masseter muscle spasm because of succinylcholine. So this is the temporalis muscle, temporomandibular joint muscle capsule, and we have the vaccinator muscle. Okay, so which has been cut, and then we have the masseter muscle. So this masseter muscle, okay, so this can become spasm, can have spasms because of the succinylcholine. So clinical uses of succinylcholine. So it is the neuromuscular blocker of choice, okay, previously, or in many settings, probably, depending on the budget of the hospital, etc. So it might be still the neuromuscular blocker of choice in many settings for rapid sequence induction of anesthesia. Okay, rapid sequence induction of anesthesia. Okay, next we go to talk about non-depolarizing neuromuscular blockers. Okay, non-depolarizing neuromuscular blockers. And why do we have this picture? Because of curare. Okay, because of curare, which is the origin of having D-tuberculorin, DTC. Okay, which is one of the previously important non-depolarizing neuromuscular blocker. So the available non-depolarizing neuromuscular blockers can be classified according to the chemical class. Okay, whether it's steroidal, benzylisoquinoline, okay, benzylisoquinoline or other compounds. Or you can also classify the non-depolarizing neuromuscular blockers according to the onset, okay, the onset of action, how fast it is. Okay, is it fast onset or is it slow onset, intermediate onset? Also, you can classify it according to its duration of action. Okay, whether it's a short acting, ultra short acting, intermediate acting, or long acting drug, okay, of equipotent doses. Okay, so so we can see, look at the long acting ones. Okay, we have the long acting ones like pancuronium, pipercoronium, alpha T tuberculorin DTC, okay, metocurine, doxycurium, okay, galamine, alcuronium. And then we have the intermediate acting. So intermediate acting acts within between 20 to 50 minutes. So the effects last for about 20 to 50 minutes. So we have vecuronium, rocuronium, atracurium, cisatracurium. And then we have the short acting one. So the short acting one is mivacurium, okay, mivacurium. And then we have the ultra short acting one, which acts and has its effects lasting for about less than 10 to 12 minutes. We have gantacurium, okay, gantacurium. And rocuronium, this drug, okay, it has the fastest onset among the non-depolarizing neuromuscular blockers. So non-depolarizing agents, what they do is they compete with acetylcholine at the neuromuscular junction. Okay, compete with acetylcholine at the neuromuscular junction. Okay, but without producing initial stimulation. Okay, it just competes with acetylcholine at the neuromuscular junction, but does not produce initial stimulation. And this can be reversed by anticholinesterases. Okay, anticholinesterases such as neostigmine. Okay, anticholinesterase. So it competes with acetylcholine at the neuromuscular junction, and this can be reversed by anticholinesterases such as neostigmine. Okay, because you know that cholinesterase breaks down acetylcholine. Okay, but anticholinesterase will block the effect of cholinesterase. So we don't have the breaking down of acetylcholine. So acetylcholine can remain, its action can remain on the receptors. Okay. So this is used during balanced anesthesia to facilitate IPPV and surgery. Okay, intermittent positive pressure ventilation. Okay, intermittent positive pressure ventilation, and also surgery. So this is a picture of how the syringe of a neostigmine. So this is a picture showing how what does the IPPV, intermittent positive pressure ventilation, look like. Okay, so you can have a look. YouTube this up. Okay, how this is. So it's a form of artificial ventilation, okay, to help people to ventilate, to act, to respirate, to breathe, okay, using a machine, the help of a machine. So common agents, okay. So we have vecuronium, okay, vecuronium that lasts, the effects last for 20 to 30 minutes. So it's used if the cardiovascular stability is important, is an important issue in that patient. So, and it has no ganglion blocking effect. And it produces the least histamine, causes the least histamine release, okay? So when you have least histamine means you have less allergy kind of reactions, okay? Less allergy kind of reactions, because histamine tends to cause allergic kind of effects, okay? So the next is atracurium. Okay, onset is within 3 to 5 minutes. Okay, quite fast. Effects last for 20 minutes. However, it causes substantial histamine release. So we have to be aware of that and be careful in asthmatics. So because asthmatics also, it's there is a lot of histamine release in asthmatics, so causing bronchoconstriction, all that. Secretions all are increased. So we don't want to see that, okay? However, the good thing about this is the metabolism of the drug is by Hoffman elimination, okay, which is spontaneous molecular breakdown. So because of the spontaneous molecular breakdown, it's the drug of choice in renal and in kidney and also liver failure. Okay, next is let's talk about the skeletal muscle relaxants. Okay, so focus now is on spasmolytics. So what condition is this? This is a patient with cerebral palsy, okay? So usually they have a lot of spasms here and there. So just a quick recap, we have talked about the neuromuscular blockers. We've talked about non-depolarizing. Oh, so sorry, we started with the depolarizing ones first, and then the non-depolarizing. The non-depolarizing, we've talked about the various types. So now we'll go on to talk about the spasmolytics, okay? So we have the ones that is for acute use, such as orphanedrine, and the ones that are used for chronic use, such as baclofen, diazepam, tizanidine, and also dantrolene, okay? So certain chronic diseases of the central nervous system are associated with abnormally high reflex activity, okay, high reflex activity in the neuronal pathways, okay, that control skeletal muscle. And because of this high reflex activity in the pathways, the neuronal pathways, that causes painful spasm, okay, spasm of the muscles, which is painful. So I think everyone knows this person and knows that he has a motor neuron disease. He suffers from motor neuron disease, okay, that involves that manifests with all sorts of painful spasms. So yeah, this is one condition that requires drugs that can help relax the muscles, okay, the spasmolytics, okay. So acute injury or muscle inflammation causes spasm and pain. So goal of spasmolytic therapy in both acute and chronic conditions is to reduce excessive skeletal muscle tone, okay, without reducing the strength, okay. So we just want to reduce the tone, okay, make it a bit relaxed, but we don't want the muscles to reduce, to have its strength, okay, strength reduced. We don't want the strength to be reduced, okay. And spasm reduction will usually lead to less pain and improved mobility. So they're more mobile, they're able to move around, okay.